Welcome to this second session of Transverse Myelitis Awareness Series that's being run by Spinal Life Australia. Really excited today to have Dr. Ben Greenberg on the agenda to answer questions and to let us know the current research opportunities and forward-thinking research that's going on in the area of transverse myelitis. My name is Ross Duncan. I'm the General Manager for Member Services of Spinal Life Australia. I think I've met everyone in the room so far, which is really good. Thank you very much for coming along today. Like we always do at the start of these meetings, I'd like to acknowledge the traditional owners of the land on which we meet and pay respect to the elders past and present. I'd also like to acknowledge the ongoing efforts of the Aboriginal and Torres Strait Islander people to protect and preserve their culture for future generations. A little bit of housekeeping before we get to the important part of this morning. There's accessible toilets out the side doors on this side. There's also exits in the case of emergency evacuations out the doors on the other side, and you can turn left or right. And then under the undercover parking area is where we congregate in case of an evacuation. So that's the boring stuff out of the way. About this morning, welcome to everyone again who's here in person today. Like I said, this is the second in a slightly different arrangement of events about transverse myelitis that Spinal Life is undertaking in 2017. We've got about 15 people, I believe, that registered for online attendance as well. So the crowd you see in the room here is just part of the engagement that Spinal Life Australia is trying to engender for people and families of people living with transverse myelitis. We're also thanking Transverse Myelitis Association in the USA for use of their video link facilities. We don't have these facilities yet, but graciously, again, TMA USA has allowed us to piggyback on their facilities, but also thanks to Jim Lubin for organising all the background work that we don't actually see, but is enabling the other 15 or so people to connect into this video link this morning. So first we'll hear from Dr. Ben Greenberg. After that we'll hear from Spinal Life Australia staff member Samantha Kent, the Access and Engagement Officer, in case you have any questions about the upcoming rollout of the National Disability Insurance Scheme in Brisbane or other parts of the States. Most of all, today I'd like to thank Dr. Benjamin Greenberg. Before we go on and introduce him and tell you a little bit more about Dr. Greenberg, I'd like to dedicate today to Colleen Segal. She's an important part of, she was an important part of the foundation of the Transverse Myelitis Association in the USA, and unfortunately she passed away very recently. So I'd like to dedicate today to keep Pauline in our thoughts, and because without the efforts of Pauline and her husband Sandy, the TMA probably wouldn't exist. We wouldn't be sharing this knowledge and linking Dr. Greenberg up with so many people. So if you keep that in mind, we'll be saying a few more words about Pauline later on in this morning's meeting. So a little bit about Spinal Life Australia before we start. I know you're all connected to the organisation if you're in the room, and a lot of people are probably connected if they're online. They're also aware of what we do. A couple of really good announcements. We've secured a $4.5 million grant from the Commonwealth Government to build a $12 million facility in Cairns with dedicated hydrotherapy specialist gym equipment and 7 fully accessible accommodation units upstairs for transition, rehab stays, but also short-term holiday accommodation. We've secured a $300,000 grant to identify barriers for people with spinal cord injury and damage in full participation in society. And we've secured another $100,000 to investigate the applications of virtual reality in staff training, development and engagement with clients across the state. So we've got a few exciting projects on the go at the moment. The structure that we're taking to the Transverse Myelitis Awareness Series is another in those, trying to reach out to more people in different ways than we have previously as an organisation. Today's an opportunity to meet like-minded people both in the room and online. I'd encourage you, if we're getting up for a break and during lunch, to really make the most of those networks, as I know you will. I know you didn't come here to hear from me today, and we've got one of the preeminent specialists in the TM in the world online, so I won't keep him or you waiting any longer. Dr. Ben Greenberg, internationally recognised expert in treating rare autoimmune disorders of the central nervous system. He's the director of Transverse Myelitis and Neuromyelitis Optica program and Pediatric Demyelinating Disease program at Children's Medical Centre. can you tell I've got scientific training because I didn't stumble over most of that? Dr. Greenberg splits his clinical time between adult and paediatric patients, which is an interesting mix, given some of our Australian specialists don't do that. He routinely consults at inpatient units of St Paul and Zale, Lipsey University Hospital, Parkland and Children's Medical Centre. His research focuses on better diagnosing, prognosticating and treating demyelinating diseases and nervous system infections. He also coordinates clinical trials to evaluate new treatments and to prevent neurologic damage and restore function to affected patients. Like I say, one of the world's preeminent specialists and very generous with his time, donating his time to be here with us today from the USA. So thank you very much, Dr. Greenberg. I'll hand over to you.
Appreciate it. Thank you for the invitation and the introduction. A few housekeeping issues on my end. First, for everyone in the room and especially in the back, can you hear me? Just by a show of hands, give a wave. Excellent. Perfect. Second housekeeping issue, for those of you here in the U.S. with me, my bathrooms are back there and down the hall that way. In the event of evacuation, we meet at the beer fridge downstairs, stock up, and then exit the building. I appreciate the invitation to speak with you today, and hopefully you're going to have a great day with your group going through a lot of things. I'm going to be focused on transverse myelitis and giving an update on research and where we stand. The last housekeeping issue, just by a wave, there are two ways to show my screen. Can you see a title slide on your screen right now?
Yes.
Yes.
Okay, so I'm going to leave it like this because if I do it this way, then I can see you as well as my slides, and so I'm going to do some arranging here. That way, if you start waving at me, I'll be able to see you. All right. So with that, so as was mentioned, I'm here in Dallas, Texas, at the University of Texas Southwestern, and I'd like to give a little orientation, if you will, to who we are and what we do. So the University of Texas Southwestern Peter O'Donnell Jr. Brain Institute Conquer Program is the full title of where I work and who I collaborate with. To give you a little geography, so within the United States, Texas is that very small region in the south. Dallas is in the northern part of Texas. You may have heard in the news the horrific flooding that's happening in the southern part of Texas along the Gulf of Mexico. Houston, Texas has been affected. We've got a lot of colleagues and friends and family down there. Thankfully, everyone's okay. The medical center fared actually relatively well, and things are back up and running within the medical center down there. Dallas, thankfully for us, was not affected by the flooding at all. On the side of your screen, you'll see a picture of the medical center in Dallas, and it spans more than a mile in a north-south direction and about 3/4 of a mile in an east-west direction. It's made up of 4 major hospitals, the medical school, and a large research campus. And it's here within the Peter O'Donnell Brain Institute where I focus my work. As you'll see on the slide, the Conquer logo at the bottom is the group that I lead. The acronym Conquer stands for Collaboration on Neuroimmunology: Question, Understand, Educate, and Restore. And each of those words form the pillar of what we do. So this is a highly collaborative group with individuals from a variety of specialties. I'll point some of them out in a moment. We're focused on all conditions where the immune system attacks the brain or spinal cord or optic nerves. And our jobs are to question everything, do our best to understand. Our job is to educate and be educated. We learn a lot from you, our patients, and our families, just as much as hopefully we impart to you. And then obviously in the end, we want to restore function and restore protection against future events for our patients. And so I thought it would be useful to go through a little bit about where we are with transverse myelitis. We've thought of it historically, and the way I've spoken about it for years, as a rare disease seeking a cure. As we're getting more and more savvy over these last few years, we realize we're wrong. It's actually a rare disease spectrum seeking various cures. And I'd actually like to spend a fair amount of time this evening talking about that spectrum, because what we've found in the last couple of years is the individual variances from patient to patient make up a huge reason for the variances in recovery, the variances in responding to different rehabilitation techniques, and the need to personalize the approach to every patient, because there are no two patients with this disease that are alike. And it's only when we stop lumping everybody together into one diagnosis that we'll actually start to make a lot of headway with this condition. So I'm going to get into the weeds a little bit with the science, and if there are questions, feel free to wave or throw something at the camera, and I'll pause and go into more detail. But I want to start with the classic description of this condition. And the classic description of transverse myelitis biology is that there's inflammation in the spinal cord. And what you're seeing on the screen over the word inflammation, all those little blue dots, are immune cells that have invaded the spinal cord of somebody who is diagnosed with transverse myelitis. So everywhere there's a blue dot, that's the immune system having infiltrated the spinal cord. Normally there wouldn't be any of those blue dots in the spinal cord. And those cells, those immune system cells, secrete a lot of substances that damage the protective coating around neurons. So by a show of hands, how many people in the room have heard of the substance called myelin? And keep your hands up if you've heard the term demyelination. Okay, so everybody's comfortable with this term. It's basically, if you think of it as the speaker wire of a stereo system, it's that rubber foam coating around the speaker wire. And when you lose that coating, the signal can't get from the stereo to the speaker as well, so the music doesn't sound as good. When we're talking about the human body, if those are the wires that are going to your right hand, if I lose the coating around the wires, my right hand doesn't work so well. If it's the wire going to my left leg doesn't work so well. So the symptom a person has depends on which wire gets affected. But what they all have in common in transverse myelitis is the immune system attacking the myelin and damaging that coating. Now, classically, we've described transverse myelitis this way, and we've said that if the inflammation is severe enough or is present long enough in the spinal cord, not only does the coating around the wire get frayed, but the actual wire itself can get cut. And we call this axonal transection. And the demyelination and the axonal transection, coupled with the inflammation, are what lead to all the symptoms, whether they be sensory loss, muscle stiffness, pain, bowel bladder issues, weakness, balance issues, whatever the symptom is. We have classically explained all of those symptoms by this damage: inflammation, demyelination, and then cutting of the axons. Well, it turns out that that's not 100% accurate when we're talking about transverse myelitis. And it's been growing over the last 4 years and really getting more clear in the last year and a half that this is only part of the story. And in order to go through the full story, I want to zoom out the lens and impart some new language. So by the show of hands, everybody in the room had heard the term myelin, and everyone had heard the term demyelination. So by the same show of hands, how many people here are familiar with the terms upper and lower motor neuron? So we have a few, okay? So not as many as the first one, which is what I usually find out. And then for my education in Australia, how common are discussions about the syndrome acute flaccid myelitis? By a show of hands, how many people here are familiar with this term and with this syndrome? So again, a few. So let me explain the difference between upper and lower motor neurons, and let me stress that if you get comfortable with the difference between these two pieces of anatomy, every question you ask about rehabilitation or symptom management will come back to this anatomy. All of it is based on this anatomy. And so getting comfortable with it will make a big difference. So this may make you feel like you're back in university or high school and nervous over the final exam, but indeed this is actually the basis of all the care we give to our transverse myelitis patients. So what's depicted on the screen is a caricature of brain. and then the several slices of brain stem, which is the connection from the brain to the spinal cord. The three parts of the brain stem are labeled as midbrain, pons, and medulla, and then the spinal cord.
Okay,
and then you see...
Sorry, Professor Greenberg, Ross Duncan again here. We're just wondering whether you could maximize the PowerPoint screen. Just for this. Yeah, that's much better. Yeah. Thank you.
Better. All right.
Thanks.
So, yep. So what you can see is the brain, the pieces of the brain stem and the slice of spinal cord. And then you see a red line going out from the spinal cord to what's labeled as skeletal muscle. And let's actually see. Is that marking the screen for you?
Yeah.
Yeah. Okay. So the upper motor neuron is the wire that goes from the brain down the brainstem all the way to the spinal cord. The lower motor neuron goes from the spinal cord to the skeletal muscle. And those two wires are what are responsible for the contractions and the movement of every muscle in the human body, every skeletal muscle in the human body. But the physiology is very different. The function of these two wires is very different when it comes to motor movement. So if we keep the upper motor neuron and the lower motor neuron as separate, we can go through the different versions of transverse myelitis. So in the description that I gave you at the beginning, the classical description of transverse myelitis, what gets damaged in the spinal cord is the upper motor neuron, not the lower motor neuron. And so it's this upper motor neuron in the spinal cord that, when it's damaged, leads to weakness, difficulty moving a limb, and increased tone and stiffness and tightness. In acute flaccid myelitis, which is a variant of transverse myelitis, the damage is focused on this lower motor neuron right at its beginning in the spinal cord. So the brain, if you will, or the control center, I should say, of that entire neuron going out to the muscle lives right in the very front of the spinal cord, and that can get damaged, leading to death of this neuron and a very different pattern of weakness. Instead of having the stiffness, instead of having the hyperactive reflexes, when that lower motor neuron is damaged, you have atrophy and you have reduced reflexes in the muscle, and you'll start getting muscle twitching in a very different way, and you do not develop the stiffness, you do not develop the increased tone. Now, both of these cells can be damaged by inflammation in the spinal cord. So in one case, the inflammation might affect the upper motor neuron. In another case, it may affect the lower motor neuron, or it may affect both. Now, the implications are quite profound for keeping those two things separate. The first is relative to causation. So the way I described damage to the spinal cord, that very first piece of the triad was inflammation, those blue cells entering the spinal cord. And in classic transverse myelitis, where that upper motor neuron is affected and you have stiff muscles and tight muscles and loss of sensation and difficulty with bowel bladder function, the etiology is presumed to be autoimmune. The immune system gets confused, and instead of fighting an infection, it enters the spinal cord and causes damage to those upper motor neurons. Whereas when the focus of damage is the lower motor neuron, we know that the immune system can do this, but there's also ample evidence circulating over the last 4 or 5 years to say that some people have a virus that directly affects the lower motor neuron, directly affects the spinal cord right at that little part in the front, and that virus damages the lower motor neuron and recruits those blue cells in to cause even further damage. So the etiology behind classical transverse myelitis and the acute flaccid myelitis variant looks to be different. In one, there's a virus that begins the cascade within the spinal cord, and in the other, there is no virus in the spinal cord, it's just the immune cells invading the spinal cord. But there are implications also then for acute therapy. So when you're in the hospital with transverse myelitis, there are some therapies we give to get rid of those little blue cells, those lymphocytes that are in the spinal cord. And then there are other therapies that we may use to try and fight off viruses. So depending on which variant you have, we may pick different acute therapies. There are implications for what I deem natural recovery. And I want to spend a moment on this notion of natural recovery. And what I want to do, and I'm going to shrink the slide for a moment because I'm going to watch your faces as I give this description, because I want to see if this is making sense. So for anyone who has been left with a deficit after transverse myelitis or spinal cord injury, the pathway to recovery has several pieces. For some people, they lay in bed at night and pray. For some people, they look at their arm or look at their leg and they yell at it and ask it to move and have these long negotiations with their legs trying to get them to move. For other people, they're in a pool and in a gym being yelled at by a physical therapist. For others, there are changes in diet. There are all sorts of ways we approach recovery. Natural recovery is when damage occurs to either the upper or lower motor neuron and the body instinctively engineers some recovery. So it can grow new myelin. It can compensate for dead lower motor neurons by having healthy ones sprout and take over the control of the skeletal muscle that was left behind, disconnected. So there are these natural mechanisms of recovery after spinal cord inflammation. The natural recovery mechanisms are going to be different to recover from a lower motor neuron injury than an upper motor neuron injury, because you need different types of repair. Now, do you grow new wires, either a new wire from the spinal cord to the muscle or a new wire from your brain down your spinal cord? All of the evidence we have found says, as human beings, we do not. We do not have the genetically encoded capability to grow a new wire from the spinal cord to the muscle or from the brain to the spinal cord. So whatever wires are left behind are the basis, the scaffolding, if you will, for natural recovery. Does that make sense? This notion of natural recovery. Now that is different, if you will, from rehabilitation. So how many people here, either themselves or a loved one, have ever taken part in rehabilitation or physical therapy? Hopefully this should be unanimous. I heard about the funds raised for the new center, including the pool and the hydrotherapist. I am happy to come down anytime and take part. I'm extremely jealous. Having a facility like that makes a very big difference. So everybody needs to take use of it. Otherwise, we will try and steal it and bring it here to the United States. So what are the implications for rehabilitation? So it turns out, and I'm going to enlarge this for you, it turns out that natural repair does some of the work for functional restoration. So everybody, or most people, assume that the way people get better after a spinal cord event is their body repairing. That's actually only part of the equation. A large part of restoration of function through rehabilitation is through plasticity. So shown here in the diagram, you'll see a couple wires, a couple upper motor neurons going from the brain down to the spinal cord. And in actuality, you have millions of wires heading down. And each of those wires does not encode a specific muscle contraction. Those wires get coordinated based on general movements. So when I stimulate one part of the brain, I don't just get a finger twitch, a muscle twitch, I get a whole limb movement in different directions. And so the connections between the upper motor neuron and then pools of lower motor neurons is quite complicated, but extremely useful from a rehabilitation perspective. Because it turns out in transverse myelitis, we almost never cut all of the upper motor neurons. That is extraordinarily hard to do, very difficult to do. And so when we're talking about transverse myelitis, it's a question of how many wires are still intact. So making up some numbers, let's say you had 1 million going down your spinal cord, and after those blue cells left, you were left with 500,000. Your job is to figure out a way to use 500,000 wires to get the job of 1 million done. And that's the notion of plasticity. And so rehabilitation is about getting your body to figure out how to get a job done with fewer wires dedicated to that job. And it's 100% possible. We see it all the time. We see people recover years, many years after their transverse myelitis, once we start approaching the rehabilitation in a very different way. And so a lot of it has to do with asking your body to recover. So when I talk about asking your body to recover, I don't mean sitting in bed looking at your legs and saying, please move. It turns out that your nervous system does not speak English. It turns out that your nervous system only responds to task-based requests. So if you want your legs to move, you have to try and move them. If you want your walking to improve, you have to work on your walking. And it doesn't just mean you work on your walking when your physical therapist is standing there watching you. It means that you work on your walk. You take the tools that your therapist teaches you, and you work on your walking every time you're walking. Because every time you take a step, your brain is trying to figure out how to use that connection. So if on Mondays and Thursdays in physical therapy you do it correctly, great. But if on Tuesday, Wednesday, Friday, Saturday, and Sunday you're doing it the old way, your brain is never going to learn. It's never going to figure out how to hardwire that compensation through the upper motor neurons. And so the implications for rehabilitation between an upper and a lower motor neuron are quite different. In a lower motor neuron, one of the implications has to do with our use of electrical stimulation. So this is a technique we use quite a bit with huge success, especially when dealing with upper motor neuron injuries, because I can take electrodes, place them over the skeletal muscle, apply a current, so the electrodes go on the skin over the skeletal muscle, and as long as there is a connection from a lower motor neuron to the muscle, when I apply the electrical current over the skin, the muscle contracts. And so if I want to train an upper motor neuron to work again, I can ask you to move a limb while applying the electrical stimulation and try and get that connection working again. What about if I've lost the lower motor neuron? Well, when I put the electrical stimulation device on, at least the current ones that we use, you don't get a muscle contraction because you need that intact connection between the lower motor neuron and the muscle to use most of the devices to get a muscle contraction. There are settings that we have learned to apply to muscles that have lost the lower motor neuron in order to get them to contract, and it's changed the way we're doing rehabilitation. And so the approaches we take when there's a lower motor neuron and the approaches we take when there's an upper motor neuron for rehabilitation are quite different. There are further implications for outcomes research. So if I have somebody whose damage is from the upper motor neuron only, both upper and lower, or just lower motor neuron, how I judge their recovery is going to be totally different. Why on earth is that important? As Ross was mentioning at the beginning in terms of funding for research and different things, if we don't know the outcomes of our endeavors, or if we lump together people who have totally different patterns of injury so that we get data that doesn't make sense, none of the work we do in transverse myelitis is ever going to pay off for a general population because we're not going to know how to measure outcomes. So we have to keep track of these different types of TM in order for the outcomes research to work. And then what most people are focused on is the restorative therapy. If I have a way to regrow myelin in the spinal cord, would it help somebody who had a lower motor neuron injury? No, not at all. It's not going to do a darn thing because they don't have that second connection. Likewise, if I have a way to restore the connection from the spinal cord to the muscle, Is it going to help somebody who had an upper motor neuron pattern of damage? Not in the least, because that's not where they need the help. And so breaking people down into subsets is going to be incredibly important for doing the restorative research that we want to do. So with that in mind, I'm going to shift gears, and we only have a few more slides, and talk about the implication for TM and what we're doing on the research side. So at least in the United States, we quote about 1,500 cases a year. Now, it turns out that this has lumped together children and adults and all of the different versions of transverse myelitis. The classic idiopathic transverse myelitis, acute flaccid myelitis, and snuck in there are a few patients who will actually have multiple sclerosis but haven't been diagnosed yet. And when we look at the outcomes, the data is all over the map. We used to quote patients the notion of the rule of threes: a third recover almost fully, a third with some disability, and a third don't recover well at all. That number is a really bad statistic and probably not true, and it doesn't take into account any treatment interventions. We still, however, despite all of our treatments, do see variable outcomes. They're better than they used to be, but they're not the same. And when we look at our community, both in the U.S. and abroad, and Australia and Europe and Asia and Africa, what we find is no two people are alike. And so I find myself as a researcher moving between population level statistics and individuals. And when we're talking about transverse myelitis, we're talking about a lot of people. And these are all individuals with their own story. These are all individuals with their own experience. And what we have found in our work in the Conquer Project is the education is happening more from our patients towards us necessarily than us towards our patients. And what we found is we really have to listen closely, because in learning about the differences between individuals, it's telling us a lot about what we need to be doing on the research side. And so the Conquer program, the Conquer TM program here at UT, we're here to provide care to patients, families, while we do research and while we treat and ultimately reverse the damage done by transverse myelitis. That's our mission. And how are we going about accomplishing it? So the collaboration. So I work with immunologists, I work with imagers, I work with surgeons, statisticians, psychologists, psychiatrists, radiologists, you name it, and everybody brings a different skill set to the table. And very important to us is a very robust circle of patients and families that we deeply collaborate with, because we found that when we lock all the scientists in a room to start hatching plans, often we get it wrong. And when we include patients and families in the process, we do a much better job. It's multidisciplinary. It's not just going to be a neurologist or a neurosurgeon who fixes this disorder. We're learning a lot from our colleagues in other disciplines. And one of the major things I've focused on while in Dallas is the integration of our missions. What I remind my patients is, obviously with consent, every visit is a research visit. Every time I see a patient, whether they're a month out, a year out, a decade out, 25 years out from their event, it's a learning opportunity for science. And we try to make sure that while we're providing clinical care, we're recording our experiences in such a way that we can learn from it in the future. And then we're trying to break the gridlock between the lab and the bedside. We're trying to accelerate the rate at which things can move from test tube and actually be a benefit to patients. And as I said, we partner with patients in all aspects of our mission. So what's the upcoming research that we can talk about? So there are a lot of projects going on, and I'm happy to take questions on all of them. The one that's probably going to garner the most attention over the next year has to do with restorative therapies. So the FDA, which is the U.S. Food and Drug Administration, it's our oversight committee over clinical research and drug-related research, has for the first time granted what's called an IND, an investigational new drug application for a stem cell that can remyelinate spinal cord. So we literally have been working with these cells for over a decade at this point. And in July of this year, the FDA granted the IND. What that means is we are not allowed to do human subjects research in the United States with a drug or a stem cell or anything until the FDA gives clearance, and as of the first week of July, they gave us our clearance. And so what you're going to see reported by the Transverse Myelitis Association in the next couple of weeks is that in the beginning part of 2018, we will perform the first in human phase 1 trial for remyelinating stem cells in patients who've been paralyzed by transverse myelitis. We're going to do what's called a phase 1 study. So this is a safety study where we're going to be taking 9 individuals who've been paralyzed by transverse myelitis and doing a surgical procedure where we directly inject the stem cells into the spinal cord. And these are stem cells that have been shown to regrow myelin in the nervous system. We've cured a lot of mice, and now it's time to take it from mouse to human and other animals besides mice, but mainly mice. And see if we can't recover function. So the way it works in the United States is there's 3 levels of trials: phase 1, phase 2, phase 3, and phase 1 is all about safety. So we're going to ensure that these cells don't, or the surgical procedure does not cause harm to the first patients who volunteer to take part in this research. So ever since I became part of the Transverse Myelitis Association and started doing work in this area, going back 15 years now or more, this has been our goal, to get to a place where we can start actually delivering remyelinating stem cells to the spinal cord, and we're excited to say that the next time we speak, I'll be telling you about first enrollments and how things are going. This is obviously an exciting project. It takes a lot of work. I can only show you part of our team. Everybody here has a different role to play, and I need about 2 or 3 more slides. But the nice part of our team is that we're not just clinician scientists or researchers or study coordinators. These are folks who get very involved in the community and try to partner up. For anyone who's been or watched the pictures online from the Transverse Myelitis Association camp that gets held every July or August, we go and we take part. This is from what's called the Messy Games, and it's self-explanatory. It's several stations where campers just get to attack each other and us with shaving cream, ice cream, pudding, you name it, and get as messy as you can. What I love about my team is they're not just committed to the science or the clinics, but they really are committed to the community as well, and we get a lot from taking part with events like these. And as Ross said, the TMA lost a giant in our field, Colleen Segal, who passed away in a horrible accident this summer, just recently, and she's going to be very missed personally and professionally. For anyone here who ever had the absolute delight to meet Pauline, you know, her smile was infectious, her love never ended, her grace was amazing, and she was really the key to the TMA connecting so many people, and frankly, for me being in this field, if the Transverse Myelitis Association and Pauline and Sandy hadn't done and what they did and weren't the people they were, I could have found myself working in all sorts of areas. But it's hard to get involved with a group like this and not just feel the passion that Pauline had and Sandy still has. And so she's going to be missed quite a bit, and we're going to be pushing forward to make her proud, because she's been waiting on the research a long time. So with that, those are just the updates and the slides I thought I'd go through. As I said, we could talk for several hours about different projects going on, but I wanted to leave time for any questions that you had. Happy to answer them. Hope this helped put things in perspective, especially when thinking about the symptomatic management and the rehabilitation. So with that, I'm happy to take questions. I already had one snuck to me, so I can start with the one that was sent to me, or take any from the crowd.
Ben, Jim, is there any way to connect in the people who are via video link to allow them to ask questions?
No, he's been sitting on my screen.
Ben, we might start with that question I gave you earlier, and Jim might come on in a minute.
Okay. So okay, can you hear me now? Okay, so somehow this muted, but the question you sent to me earlier was a symptomatic question. It was a woman, I believe, who had had transverse myelitis diagnosed last summer in August of 2016, and she indicated she was taking a drug called Lyrica or pregabalin twice a day. What she said was that she was having sensory changes in her legs and her feet and a lot of muscle stiffness, and asked if there was any better drug for those sensory disturbances, and was I aware of something called myofascial release, and whether or not myofascial release could help with these symptoms. So it's important to understand the sensory aspects and the stiffness that goes with transverse myelitis. So it turns out that those upper motor neurons that I pointed out and spent so much time belaboring the point over and over again, a lot of the signals they send down the spinal cord are actually stop signals to the lower motor neuron. So if you lose the connection between the upper and the lower motor neuron is unbridled to just throw a party and tell the muscles to contract and tell the muscles to increase their tone. So the stiffness that somebody has is because their lower motor neuron is no longer regulated by that upper motor neuron, so the muscles get tight. So there are lots of ways to try and loosen up the muscles. Myofascial release can help, but it tends to be temporary. People tend to have it done and say, oh, I feel great for 30 minutes or an hour and a half, but slowly the stiffness kicks back in. Some people use acupuncture and can get some longer relief. Stretching plays a big role. There's a reflex arc between your muscle and the spinal cord. So the more you stretch out your muscle manually, the less stiffness you'll have. But in the end, sometimes we have to use medication. There are several medicines that are used pretty routinely in the United States for this. One is baclofen in the United States, tizanidine, another medication called dantrolene, and sometimes some medicines that are related to Valium or diazepam are used to manage the stiffness of transverse myelitis to directly try and relax that muscle. Separate from stiffness are the sensory issues that can happen when the spinal cord is damaged. So we focused on the motor side. How do you move? I didn't mention once the sensory side, but within the spinal cord are all the inputs coming from your body to your brain so that when you stick your hand on a hot stove, your brain gets the signal and you know to drop some choice curse words as you remove your hand and you've scalded your hand. So when those fibers are partially disrupted, your brain only gets partial input. It doesn't get the full picture. And so when it's left with an incomplete sensory picture, it likes to make things up. It likes to fill in the gap. So sometimes people will feel burning, squeezing. Sometimes people will feel coldness. Sometimes people will feel tingling, pins and needles. And so what we do are we try a lot of different medicines. Lyrica is one, but there are a lot of others to try and help the brain adjust to that sensory and that impartial sensory information coming in, and try and get the brain to stop making things up to fill in the gap. So what we recommend for patients who have tried one medicine but it has not helped is to work with their clinician to keep trying, because more often than not we can find a medicine that will get the job done. But it's a lot of trial and error.
Do we have any questions from the floor here? Louise?
Just to let you know, Ben, that tizanidine is still not available in Australia, which, having had the opportunity of trying it several times over the last 10 years, frustrates me enormously. But at this stage, we're still waiting until it is totally available at some point in the future.
Yeah, and if I want to start an illegal business, I'll just start sending shipments over to Australia. We can work out some sort of trade. We'll talk. Jim, stop the recording, and then we'll talk. So.
later, Jim.
Then I also wanted to mention that early on in your presentation, you talked about the current treatments for the acute onset. Once upon a time, we always talked about steroids and then other things such as intravenous immunoglobulins and plasma exchange. Amongst therapies that are used in that acute phase, is there any new therapies that are used at that time? Or are they still the sort of basis for the initial?
Yeah, those are still the pillars of what we use. We've been dabbling with some other agents here in Dallas and with some colleagues. For patients who aren't responding to the standard therapies, we have a protocol over the last several years that we just published on using a high dose of a drug called methotrexate. It was controversial because in certain cancer settings, methotrexate can actually damage the white matter of the myelin. So everyone said, well, why on earth would you use methotrexate in this setting? We've actually found that in some folks with a certain pattern of inflammation, the methotrexate does a great job of getting rid of that inflammation. So we've used that some. And then we're branching out into different immunosuppressants in very small numbers, but those are being reserved for individuals who just aren't responding to therapy the way we want. You are going to see clinical trials start up over the next year or two with new agents referred to as neuroprotective agents. So these are drugs that we're going to plan to give to patients while there's inflammation in the spinal cord to protect the axons. Because the idea is if we can regrow the myelin, all we have to do is kind of get over the hump, let the inflammation go, but we have to protect those axons. And if we can do that, then we think we'll have better recovery. So we're going to be looking at clinical trials in individuals who have inflammation in the nervous system using these neuroprotective agents.
Ben, the selection criteria for the people who will participate in your trial, will they be restricted to people who are more recently diagnosed, or will they also include people who have had transverse myelitis for some years?
Yeah, it's a great question. What we negotiated with the FDA on is this will actually include patients who are all the way out 10 years from their event. So we're not restricting to individuals who had it just within the last few months.
And the results when you tested in mice and other animals were very significant. Did all their functions return?
Yeah, so when we looked at the model we used in mice and rats, we looked in one model which had brain-based demyelination and another model looking at spinal cord. And what we saw on the brain-based was some responders and non-responders. It was about 50-50 in the mice, where half the mice recovered and regrew myelin beautifully, and half the mice had issues. And we're looking to understand why some would respond and some not. In the spinal cord, we saw significant improvements in function, but one of the things is the lesions that were created in spinal cords were on the small side, and we are going to be enrolling patients in the trial who have more significant damage. And the reason for this, and I'm very open and public about this is a safety trial, and so one of the negotiations we had to have was we had to agree on a group of patients who were so severely affected that there's little chance of us making things worse. Because we're going to do a surgical procedure. We're going to directly inject into their spinal cord. So one of the concerns from the FDA is if I take somebody who's ambulatory, who's walking, and I subject them to a procedure and they turn out worse, that was a big concern. But if I take somebody who has significant weakness and is not walking, the likelihood of me negatively impacting them is very low, but I've got a lot of room to improve. And so that's why in the phase 1 trial we're selecting individuals who are not ambulatory.
And do they have more than one treatment? Is it, so you do a stem cell injection, do they do once or is it multiple ones?
In the phase 1 trial, it's a single surgical procedure, one trip to the OR, but multiple injections during that OR trip. So we cover the size of the lesion. We directly inject into the lesion the cells. And in animals, once the cells are in, they migrate in each direction. They actually move through the spinal cord. So we know that if we inject in different spots, we can cover a large area of the spinal cord.
Hi, Dr. Greenberg. It's Jill Bennett. Chelsea's doing very well. Thank you very much. She's moved to adults neurology now, which seems to be a lot better, or better communication. Just one question that a lot of mothers of teenagers are asking is, what do you feel about the HPV vaccination?
Yeah. Yeah, we get that question a lot. So we've gotten good data on the overwhelming majority of vaccines. So we've got good data on flu, hepatitis, measles, mumps, rubella, you name it, that we are not finding links or causation links between them. HPV is newer, so we have less data. What I can tell you is for all of the transverse myelitis patients I know who have had TM and were subsequently vaccinated with HPV or any of the other vaccines I just mentioned, I am unaware of a single case of recurrence of inflammation in the spinal cord. And so, in general, we are saying to move ahead with vaccination. Even in settings where there is a concern that vaccine triggered an inflammatory event, which is a very controversial area, and I won't go down that road today, if you take the people who really believe that was the cause, it had to be a perfect storm of events. You're never going to step into the same river twice, and so the likelihood of somebody having a recurrent event is astronomically small, even if you believe there is a link between them. So it's not something we've seen happen, so we've been fine doing the vaccinations.
Great, thanks.
Yeah.
Suzanne. Dr. Greenberg, Suzanne Mulligan speaking. My TM was not an acute attack. It degenerated over a period of months. And I'm now in a wheelchair. Will you be looking at people in that situation as well in your trial?
Yeah, so the key to the trial is that you've had the diagnosis of transverse myelitis, and we can confirm that that was the diagnosis. And so when somebody declines in function over more than a month, we have to explain that decline. So there are a couple potential reasons. So it is rare for inflammation to smolder for more than a month, causing just kind of stepwise decline over many months. And so it always sends up a flag for us to say, well, was there inflammation? And then we can see people decline functionally depending on what they're doing from a therapy perspective or other things. But the inflammation may be gone, but they're still dealing with after effects. Or we look for other potential explanations for the damage to the spinal cord. So to us, the timeline in and of itself doesn't change whether or not somebody can be in the trial or not. But it definitely causes us to examine the diagnosis whenever somebody is still declining after the first month. And so we always want to wrap our heads around why. So I do my version of the Spanish Inquisition in my clinic room, where I really have people go week by week and relive the experience to tell me, what could you do at the end of the first week? What could you or could you not do at the end of the second week, the third week, the fourth week? And I encourage everyone to do this exercise with their family. I'll bring 4 family members in and get 6 different answers of exactly what was going on. And it's hard to remember after being through such a traumatic event, kind of what was happening in week 1 and week 2, and when you're in the hospital, it all runs together. But a lot of times, or I should say the majority of the time in transverse myelitis, the inflammation is there and gone in the first 30 to 60 days.
I've had several MRIs to try and find my inflammation, and wasn't successful till the 7th MRI, and subsequent MRIs don't show anything either. So it was very difficult for the doctors here to diagnose what had happened to me because it was such a slow onset.
Yeah, again, when there's slow onset going over more than a month, we always, and it's always important to remember there are lots of ways to get spinal cord damage. The myelitis specifically means it's the immune system. We see a lot of patients who have other pathways to getting the damage. And so ensuring that everyone's comfortable with how the designation of inflammation in the spinal cord was made is important for every patient. What is the evidence? Because we're not doing spinal cord biopsies on everybody. We're not taking everybody to the operating room, taking a little piece of spinal cord, and then looking for those little blue cells. We're using circumstantial evidence, the MRI and spinal fluid, and the history, what we experience, what you experience over time, to build the circumstantial case of, did inflammation commit the crime? Is inflammation the guilty party, or are we going to blame something else for the damage that was done? And so there are oftentimes, even when we talk to families after very thorough workups and say, listen, I think this was transverse myelitis. I can't promise it was. I'm going to call it transverse myelitis because your insurance company keeps calling me and they need me to give them a diagnosis, and so I'm going to give them a diagnosis. But you and I know that it's transverse myelitis with a little asterisk next to it, and I reserve the right to change this in the future as I get smarter and figure out other ways to make this diagnosis. And so whenever we have somebody where, and it can be very difficult, sometimes we put a little asterisk by the diagnosis and say, listen, we need to keep an open mind. Now, once the damage is done to the spinal cord, whether inflammation was the culprit, the criminal actor, or something else, the rehabilitation, it can be quite similar. So whether you are damaged from trauma or from blood flow issues or from inflammation, the concepts we use in rehabilitation overlap quite a bit. So in the long term, it may not change exactly what we do for recovery. In the short term, it makes a big difference in terms of what we do for treatments.
Thank you.
Do we have any more questions from people who are linked in via video?
Ben, are you able to see the questions? There's 3 that were posted.
Let's see. Are they in the... Oh, I'm looking in the chat. Okay. Now I see them. I have to expand my screen. Okay, so one question was, if you had the 3 days of steroids in the hospital and were discharged, can inflammation cause further damage if the steroids didn't help remove the inflammation? So what I tell my residents and my medical students and my trainees is, in transverse myelitis, your first job is to put the fire out. So if the garden hose you use doesn't work, you need a bigger hose. So if steroids don't work, you need to move on to plasmapheresis or other drugs. So in general, steroids, for most patients, will slow, stop, or reverse the inflammation, but there are a lot of patients who need additional therapy. And so everybody is different. I've had patients on steroids where they, a week later, are hop, skip, and jumping out of their bed. And then I've had patients where I've had to do a lot of things beyond steroids. And so it is, steroids in and of themselves are not a guarantee of putting the inflammation out. And so it can be difficult to know. The second question that's on here is there still a point in regrowing myelin if the axon is damaged as well? This is from Jenny. It's a great question. And the answer is yes, because we never cut all the axons. It doesn't happen. There are always axons left intact. And so my problem is I don't know who's who. So if 2 people who've had transverse myelitis roll into my clinic, both unable to walk, one of them may have hundreds of thousands of axons that are intact with no myelin, and the other one may only have 50,000. I can't tell the difference, and MRIs can't tell the difference between those 2. So we will pursue remyelination therapy in each until we can prove who are going to be the responders or non-responders. The next question from Valerie is about medical advice around Lyrica, which she had trouble changing over. They suggested an epidural injection, and I'm frightened to go ahead with the injection for fear of becoming worse. Comment on the use of both drugs and epidural injections. So obviously I can't go into specifics about your case without the details, but in general, Epidural injections are used if we think somebody has an arthritic pain in the spine. So the key is the diagnosis. If somebody has a facet joint, which is the joints of the spine that is inflamed and causing pain, epidural injections are perfectly reasonable and safe to do after a spinal cord event. The risk to somebody with transverse myelitis is no different than the risk of anybody else getting an epidural injection. The key is making sure it's indicated. So you have to spend time talking to your clinicians about what kind of pain you have. My patients have often 2, 3, or 4 different types of pain all going on at the same time. They may have burning pain in their feet, muscle ache pain at their back, muscle tightness pain in their thighs, and if they come in and they say, Dr. Greenberg, I still hurt, and I just prescribe one drug, there's no one drug that's going to cure all 3 of those things. And so you have to spend time breaking down the different types of pain you have because they may require different treatments. Lyrica is great for neuropathic pain, but it's not going to do anything for an arthritic joint. An epidural injection, however, isn't going to do anything for neuropathic pain, but it would help with an arthritic joint. So you have to break down the pain into the different types. And then it looks like 2 more. Follow-up from the question of steroids on how do you know if the steroid is not working. They haven't had a follow-up since discharge or the results from the lumbar puncture. So it's important to get back in touch with your treating physician and let them know where you are symptomatically. And they have to decide, do they want to follow up with yet another MRI to see is the inflammation gone or not. It is possible for the inflammation to be gone, but recovery not happening yet. And so, or it's possible for the inflammation to still be there and the recovery to just be partial. So each case is a little different. We have to decide, do we need to re-image to prove whether or not the inflammation's gone? And then the last question here is specific to rheumatoid arthritis. Is somebody with rheumatoid arthritis at a greater risk of relapse? In general, no. So just rheumatoid arthritis in and of itself does not lead to independently greater risks of relapse, but any autoimmune condition raises the concern for systemic autoimmunity for conditions like neuromyelitis optica or multiple sclerosis, and so making sure that people who have one autoimmune condition who develop transverse myelitis are tested for those other conditions are important. But in general, rheumatoid arthritis in and of itself is not a risk factor for relapse. Things like lupus and Sjogren's are much bigger risk factors than rheumatoid arthritis. So I think I cleared out those questions.
Okay.
I just have one more question, Dr. Greenberg.
Yeah.
It's Ross Duncan from Spinal Life Australia again. One of the other groups of people that we work with quite closely are survivors of polio. When you mentioned damage to later motor neurons and sprouting of motor neurons again, it seems to be a commonality between both groups, TMers and people living with post-polio syndrome. That's taken into account when allied health professionals and GPs are prescribing rehab treatment for hydrotherapy or gym-based rehab in post-polio patients. Is that also an important consideration for people seeking treatment for TM, rehab-wise?
Yeah, so we use a lot of aquatherapy when we can get access. Access is the problem for us. You know, I think there are just too few facilities and too few therapists really trained on how to incorporate aquatherapy into the regimen. The beauty of aquatherapy, whether it's an upper or lower motor neuron that's damaged, is it takes gravity out of the equation. And it's amazing what a person's muscles can do when gravity is out of the equation. So what I tell my severely affected patients is you will walk in a pool before you walk on land. Even with harnesses and de-weighting systems and very fancy devices for treadmill walking, you will do more in a pool because you don't have to worry about your trunk. You don't have to worry about center of gravity. When done correctly, you can do a lot of things in a pool. And so for individuals who are not walking normally, I'll have them do aquatherapy to get their mechanics right in the pool before you try it on land. So one of my favorite facilities are pools that have treadmills in the pool with cameras in the pool and a TV monitor above, so you can walk on the treadmill in the pool and you can see your legs walking on the screen, and then they can raise or lower the height of the treadmill, because as you lower the treadmill and the water goes higher to the chest, it's easier to walk. And when we want to increase the difficulty, we raise you up and make you start doing more of the work and controlling more of your trunk. And that's where we can change how hard it is. And so aquatherapy in the post-polio world and in the world of transverse myelitis is a wonderful tool to use, and we encourage everybody who has access to get into a pool.
So, a slight follow-up to that, is there the possibility of damaging those sprouts with overexertion or higher degree of difficulty of exercises attempted?
Yeah, this has been a theory that's been batted around for literally about 100 years now, and we don't think so. So at physiologic rates of firing, we do not think you can damage, even if you go to exhaustion, we don't think you can damage a sprouting neuron. There's a higher controversy around direct current electrical stimulation of muscle that's been denervated, and what are the pros and cons of that. But through physiologic work, anything exercise-based, I have not found any data to say that it'll actually inhibit recovery. And so we tell people, listen to your bodies. The real problem with exhaustion, quite frankly, is people stop mechanically doing things right. They don't listen as intently to a physical therapist. They start to swing their leg a little bit more, and that scares me more than anything else. And so I don't think there's a harm, even as that sprouting is occurring.
We've got a physiotherapist sitting at the back of the audience nodding profusely.
Well, wait, are they nodding up and down, or are they nodding like this?
It's a good nod, nodding up and down.
It's a good nod. Okay.
So, were there any other questions from the room? Yeah.
Ben, I'd just add to that discussion on hydrotherapy. That was my favourite form of therapy, because it not only helped me get mobile and feel more confident that I wasn't going to fall over, or if I did, it was, not any serious consequences. But it also helped me sleep a lot better and improve my pain level. And I got some friends involved, so it became a social event. So just to get the word out there, it is a good form of positive sort of effort you can do towards recovery, but you can make it a social or an enjoyable event. When we live in a climate such as Brisbane, where it's,
summer all year round.
Yeah. So I just wanted to add that to your sort of discussions on it, on the risk.
Yeah.
We have.
It's always a good thing.
Yes, Dr. Greenberg, this Anthony here, the physiotherapist that was just recently referred to. I just want to say thank you. Lots of great comments and perspective on rehab in general. And it's really fantastic to hear the coordination between different disciplines is essential, especially with such a complex presentation for a lot of patients. I've had the fortunate opportunity to work both at the acute center or acute stage of it in the hospital rehab, like post-diagnosis, all the way to now working out in community. And one thing I can comment on that I think needs to occur a little bit more inside the hospital system is the discussion of the longevity of rehab. I found a lot of people who are first and newly diagnosed, there's a particular kind of immediacy in their mind that if I don't get this now before I leave, I won't ever get this when I'm back into my home environment or whatever. And we all want immediate results, yes, but I think there's a very small appreciation for, in many cases, the unfortunate lifelong management and recovery of this. And that's one thing that I find I spend a lot of time with my patients and clients discussing the long-term goal setting and the long-term focus of it. And, sometimes I think it's a bit affronting for some people. It can be very stressful to think of it, but I find when they circle around that, there's a lot more of a track work ahead. So I'm not sure if you can comment in the U.S. I know that when I was working in Canada, there was a lot more of that discussion very early on. Pretty good.
the notion of time course is a complicated and very poorly communicated topic between practitioners and patients. I will list for you the top, let's call it 5, maybe we'll keep track, the top list of miscommunications around timeline that occur. Number 1 miscommunication is whatever you get by a year or 2 years, and people fill in the blank. They make numbers up all the time. 6 months, a year, whatever it is. Practitioner will say, whatever you get at a year, that's all you're going to get. That there is 0 scientific data to support that, and in fact, every study that has ever been done supports the exact opposite of that. The key is when you stop trying, that's all you're going to get. There isn't a spontaneous, outside of divine intervention, there isn't a spontaneously genetically encoded recovery. And so remember, the language your body speaks is a task-based language, not English or prayer. You have to do things in order to improve. So if I'm a physician and I tell my patient, whatever you get at a year is all you're going to get, guess what all my patients do at a year? They stop seeing the physiotherapist because I told them that's all you're going to get, so they never recover after a year. So that's the number 1 miscommunication. The second miscommunication that occurs is that you get better by going to see your therapist. You do not get better by going to see your therapist. You get better by doing therapy, whether your therapist is there or not. Your therapist is there to train you on how to do it, but you have to do it every day. So what I tell patients is if you win the lottery and you are vacationing in Hawaii, you better still be doing therapy every day on the beach in Hawaii, because there is a use it or lose it phenomenon after a spinal cord event. You could recover beautifully. Stop doing your therapy, you will lose function, because part of that compensation comes from repetition, 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 and so you have to do it every day. Third largest miscommunication that occurs, so to your point, you are right, there is a lack of communication about longevity of recovery in hospitals. Likewise, however, I hold my therapy colleagues their feet to the fire. There is a lack of communication in the hospital about the different types of therapy that happen simultaneously. If I take an able-bodied individual and I paralyze them, even if they're going to go to full recovery, there is a period of time where they are not walking. They have to learn certain life skills to be independent. So they have to learn how, and some of you went through this, how to dress, how to transfer, how to go to the bathroom, how to get into and out of a car. Everything changes in terms of life skills. It turns out teaching somebody how to dress themselves in a chair or transfer to a toilet or transfer to a car or whatever the case would be does nothing for recovery. It has nothing to do with recovery. Those are skills that are needed for independence. Then there's a whole host of things we're going to work on for recovery. Standing in a standing frame, bearing weight, working on a locomat, getting in the pool. Those exercises that work with a therapist does nothing to increase independence. It's going to do nothing to teach you how to move from a chair to a car. And the problem that happens with a lot of therapists, quite frankly, is when working with patients, they don't tell the patients, right now we're working on independence. What I'm teaching you right now has nothing to do with recovery. Don't worry, in the second hour we're going to work on recovery, but you got to go home and lead your life while waiting for your legs to improve, so you need these life skills. So a lot of people leave their acute care experience feeling as though they weren't being challenged to walk again, whereas the therapists are saying to themselves, at least in the United States, well, you know, Ben was leaving the hospital in 4 weeks. He needs to know how to dress himself and live his life. And so part of the communication has to happen in therapy about whatever is being taught, the reason it's being taught. People have to understand that until you get core strength, you can't walk. People, my patients say, well, I go to the gym and I spend all this time on the mat, leaning over and picking things up and leaning over and picking things up. They never walk me. I want to walk. And we have to remind people, if your core is not strong, you can't walk. There is no walking without a core. And so the communication between our therapists and patients also has to improve around why are we doing the exercises we're doing.
Yeah, absolutely, 100%. Yeah.
Okay, do we have any more questions?
Yes, there's more online, Ben.
Okay.
woken
A couple of years ago, Adam Kaplan reported a link between IL-6 and transverse myelitis. Has there been any more research on it? It turns out, so IL-6, which is one of the proteins inflammatory cells secrete, there was a paper that came out years ago showing that the more IL-6 you had, the more damage you had. Most of those patients probably had neuromyelitis optica. So it turns out IL-6 is a major component of the pathway for neuromyelitis optica, and some of those patients were probably included in Dr. Kaplan's study. So IL-6 may play a role in a lot of transverse myelitis, but it may not be all. It probably plays the biggest role in neuromyelitis optica. Oh, we're saving the best for last. Dr. Greenberg, do you have any tips on how to tackle doctors who do not take the condition seriously? Yes, but this is a family-rated video, so I'm not allowed to use the language I would use. So we're going to have to communicate that in a different way. In all seriousness, though, part of this is about time and getting that human connection with your clinician. You have to find a way to get them invested. We could spend an hour talking about how you do that, but in general, you get further with niceties than rancor, even if you're angry with them. Try to find ways to connect. It's always impactful if a patient says to me, Dr. Greenberg, I really appreciate your time, but I don't think you're hearing me. That phrase is a very powerful phrase to physicians because it simultaneously says that somebody's appreciative, but they're just not feeling understood. And if a physician doesn't slow down, stop, and really listen at that point, then you really have to look for another clinician. And so if you ever feel like you're not being heard, saying that in a very disarming way, not try and hold back the anger and the frustration, and really see if you can get them to connect is a great way to try and slow things down. But sometimes, if it's just not working, you do need to just consider seeking out a new clinician, and that's where your community becomes important. Talking to other patients, other families in your community to try and find out, are there individual practitioners there who may be more in tune with these issues may be important.
Okay.
I think that's the last of the online questions and the last of the questions for the room.
Yes.
So thank you very much for your time, Dr. Greenberg. As we said at the start of the day, dedicating the day to Colleen Segal, I think that's a pretty good example of that she would have been proud of making this connection and us continuing the connection into the future. So thank you very much for your time. I think if everyone in the audience could give Dr. Greenberg a round of applause. So I know it's 8:45, I think, on Sunday night there, Dr. Greenberg.
Yep.
And I know you must love Australians because you've got a boomerang hanging on the wall in the background.
I was waiting for somebody to comment on that right there.
I reckon it probably was a 4-leaf clover just when you got off the line to the Irish a minute ago, but thank you very much for the effort anyway.
I switched it out.
So thanks once again, Dr. Greenberg. Your time
My
is
pleasure.
greatly appreciated, particularly when you give it on a voluntary basis on a Sunday evening. So I'd like to thank you again.
Absolutely. Thanks. Enjoy your day.
Thank you very much, Ben.
Oh, Ben, we have one more question online. Do you see the last?
It's an easy one.
Wait a minute. It might be my screen is too small. Hold on.
It's not as big as Texas then.
So this the individual is talking about complex PTSD, which in the United States stands for post-traumatic stress disorder, as well as transverse myelitis. Can these two conditions be treated together? So as Adam Kaplan does a great job of talking about, there is a huge interplay between the emotional aspects and the psychology and psychiatry that goes into brain functioning and what happens to us after transverse myelitis. And so a key portion of our multidisciplinary team is working with not just physical therapists, but emotional and mental therapists, psychologists or psychiatrists, because both for the individuals and the families, there is a profound impact of the damage that happens to the spinal cord on just life and quality of life. And so it's really impossible to treat the long-lasting impacts of transverse myelitis unless we treat the emotional aspects and the mental aspects of it as well. And so both of them have to be managed simultaneously. It's a good question.
Right, I think that's it from us, Dr. Greenberg. Again, thanks very much for your time and your commitment to the cause. Thanks again.
Thank you, Ben.
Take care.
Well, that was pretty enlightening and pretty good quality video link that we were able to take advantage of thanks to the Transverse Myelitis Association in the USA. As I said before, we'd like to bring you up to date and offer you the opportunity to ask questions and perhaps give you a bit more information about the National Disability Insurance Scheme. So we invited Samantha Kent, Spinal Life Australia Officer for Access and Engagement. So Sam, do you want to come up the front? So if you've got any questions about the NDIS, Sam can give you the inside track.
I won't take up much of your time. As Ross said, my name is Samantha and I'm the Access and Engagement Officer for Spinal Life Australia. I've been with the organisation almost 10 years in the personal care department, and late last year I was put into this role, which is about assisting our clients and members to learn about the NDIS and get into the scheme and prepare for what's called your first plan meeting. So I'm just going to today give you a very brief overview of what the NDIS is so that you can all start to think about how it may be something that you could access or how it might impact on your life in the future. Because the NDIS is the new way of funding support for people with a disability throughout Australia. And even if it doesn't impact you anytime soon, it may be the only way that you're able to access support and funds in the future. So it's good to start having a bit of an idea of it. The NDIS, National Disability Insurance Scheme, is managed by the NDIA, which is the agency of the NDIS, and it's been implemented around the entire of Australia since 2015. They began implementing it throughout Victoria and Sydney. 2016, they began implementing it throughout Queensland. We're currently going through a massive rollout with it in the Bundaberg, Rockhampton, Ipswich areas. And then we do expect it to start rolling out in Brisbane, Gold Coast, Logan, those kinds of areas next year. So with anything like a scheme like this, it's the biggest social reform in Australia's history since Medicare. So anything like that, it's going to take a bit of time to roll it out and to assist people to get into the scheme and to understand how it all works and how it can benefit you. So I'll just give you a bit of a rundown on how you access it. There is an eligibility criteria. You must be 65 or under to access the scheme at the time of its rollout in your area. So if you are over 65, unfortunately you won't be eligible for the scheme. However, there is some other options available to you, such as My Aged Care, or if you're currently receiving government funding, then you will go into what's called continuity of supports. You need to have a permanent lifelong disability to access the scheme as well and be a resident of Australia. So two ways that you'll find out about the scheme is one, if you are already funded by a state government funding, Disability Services Queensland, SCUR, any of those sorts of funding bodies currently, they will make contact with you as it comes to roll out in your area to let you know, hey, the scheme's now coming into your area and it will replace any funding you've got right now. You'll get a letter, they'll tell you how to access the scheme. If you're not already getting any funding at all, then you'll need to register with the scheme. It's a 1-800 number you call. You'll need to register when it comes to your area. How we are assisting you as an organisation is providing you with as much information we can on the current rollout and what you need to do to get into it, but also to prepare for what's called your first plan meeting. Because the way that they provide the funds to you is they sit down and have what's called a plan meeting with you, where they ask you a series of questionnaires and get a bit of an idea of who you are, where you live, what the kind of support is you get now, and what support you might feel you need for the next 12 months. So that could be anything from equipment, personal care, home maintenance, that sort of thing, anything that you would need in order to live a good quality of life in your home and to also access the community. It also includes being able to have support to get a job, to go back to study, anything to do with your health and well-being, because the whole idea of the scheme is to allow people with a disability in Australia to improve their health and well-being, get back out in the community, get back into employment. That just builds a stronger community for the society for whole of Australia. So that's the whole idea around it. Now, what I've done for today is I've left on the table at the back my business card and just a small handout, just to give you a bit of a start. If you feel that you might be eligible for the scheme, this handout will tell you when it rolls out in your area, depending on where you are, and gives you a bit of an overview of it. Take my card. Please feel free to give me a call or an email, because I can answer your direct individual questions in a much better format than that, because it is an individual scheme. So it's based on what you as an individual need in order to live a good quality of life. The current schemes that we have are based on where you had an accident, or how you got your disability, or who's got the most funding currently, which organisation's got funding for you. You don't have a lot of choice and control, but with this, it's all about you. It literally is about your choice and control. It is individualised. So the best way I can help you is if you contact me directly using my business card, because then you can ask me direct questions about your individual situations, and then I'm going to be able to give you a lot more answers that are more suited to your current situation. Yeah. So that's all I was going to talk about today. NDIS is a massive thing that's being rolled out through the whole country. You're going to see lots of it in the media, but I didn't want to overwhelm you today with a lot of information, because I know that's not what you're here for today. But just know that as an organisation, we are here to support you to get into the NDIS and to access any services that you might feel that you need in the future. So please feel free to contact me anytime, contact the organisation in any way. If you are already connected with Jeanette, Jeanette can get you in touch with myself. You can call just the main switch and I'll put you in touch with me. Whatever it is that we need to do when the time comes for you to help you get into the scheme, we will be here for you. So please feel free to make sure you contact us. Cool. Thank you.
Did anyone have any questions for Sam straight up?
Well, it's my perennial question.
Yes.
I'm over 70.
Yeah.
So it's my age care. Yeah, I realise that. So how are my age care?
My age care, yep.
Actually, so that's one of the reasons I asked.
Yep.
So did anyone have any specific NDIS questions before? Because Sam's like trying to help people across questions. But that's a really good question. The My Aged Care scheme, or the My Aged Care funding system, has gone through a whole range of changes in a similar fashion to make it all about, or theoretically make it all about the consumer or the customer. So
there is a number that you can call up and get.
Okay, great.
So there's a number you can call, but we're also trying to work out whether there's a way that we can help our members and clients navigate what's a complex system.
Okay. Yeah. That's good.
So we can talk one-on-one. I can maybe get to the main number, but it's a complex system of.
It's a little bit more complicated than the NDIS, yeah, exactly.
But they've subsumed state-based funding back into the Commonwealth funding, which makes it even more complex, and that's undergoing changes to a similar degree to the NDIS, and there's more changes coming around My Aged Care. So,
okay,
it's very complex.
Welcome to the maze.
There's cheese in there somewhere. Sam works to support people trying to access the National Disability Insurance Scheme across Queensland. Like you say, take her number, take her card,
and I'll hang around.
Contact her and ask any questions.
I'll be around.
Yeah, it's a complex system. We found some really good outcomes. We found some strange decisions being made, but there's a appeals process, a whole range of other things going on. Right. So, you're going to hang around?
Yeah, I'll hang around.
All right. So, we're almost at the end of today, but I thought we'd provide opportunity for Louise Remington, the Member Network Facilitator, to address you and to let you know what's been happening around the network, and to pay a little bit more of a tribute to Pauline. Spinal Life Australia supports about 12 member network groups all around Queensland. There's new ones starting up on Bridley Island. There's groups from the Gold Coast to Cairns up North Queensland out to Toowoomba. Some focus on post-polio alone, some are an amalgam of post-polio and spinal injuries network members. Louise is the facilitator for the Transverse Myelitis Network, as you know. And I thought, given that she knows Pauline much better than any of us, I thought we'd let her speak to you about Pauline and let you know what's coming in the network.
Well, hi everybody. Most of you I know personally, some of you for many years.
You can shout it.
And who's that fellow in the striped shirt?
Yeah, that was a little Should I leave now?
Welcome to today. I think, as always, Ben is a fantastic speaker and has a very great ability to be able to explain complex medical things to the average person who doesn't come from a scientific background. So forgive me if my pronunciations aren't quite as up to scratch as Ross's. That's not my background, but it's what I try and learn about all the time because there's so much happening. And as Ross said, I did want to just speak for a little while about Pauline and Sandy Segal. Pauline actually got transverse myelitis in the very beginning of 1994. And Sandy, if you've ever had the pleasure of meeting him and getting acquainted with him, you know he will move heaven and earth to do anything to help give anyone he loves, such as Pauline, his wife, the best opportunity to make a recovery. And he searched and could find nothing that was available, no support groups, no information groups, no specialists that actually specialised in that field. So he decided then and there that he was going to start up this group, and he wanted to make it based on the internet so that it would be accessible as much as possible. Sandy had a great vision for the future. He was someone who was thinking not only of now or next year, but he had a 5-year and a 10-year plan. And about 2 years ago, he'd been thinking that the TMA had been operating very well just with the present committee on it, most of whom have been on it since the onset in 1994. But he began to worry, thinking, well, what happens when someone in our team is no longer able or willing to be able to participate and continue that service that they've been providing? So a big decision was made with the TMA to start fundraising and to appoint a CEO who is tutorous, so as to make sure that the TMA would continue long after the original committee. So that original committee was a really interesting collection of people coming from all over the US, but it actually included a couple of people from Pakistan and India who happened to be doing studies in various fields and who Sandy sought out. And I guess in my 2 visits to the US for the conferences and having the opportunity to have dinner and spend social time with both Sandy and Pauline, Sandy was the one with whom you wouldn't want to try and block. If he had something that he wanted to achieve, somehow or another he'd go through it, over it, round it, but he'd find the way. And beside him was always Pauline, who had an incredibly gentle, loving soul. She was one of those people with whom you felt an almost instantaneous connection and a very sincere connection. And I admire the fact that over the course of all the time I've known her, I could walk into a room with 500 people and she'd get around to me and she'd say, Louise, how are you? And I'd think, my goodness, you know, that in itself, she related to people individually. So together they were an almighty team, the two of them. And at this stage we're not entirely sure what Sandy's ideas are for the future, and he's probably not sure himself. But it's going to take a long time for him to adjust and for the whole of the TMA to adjust, because that's how much and how important Pauline has been to the members of the TMA. So in due course, we hope to hear from the TMA. They've suggested in the next 3 or 4 months that they'll sort of let us know just as to what the future is going to hold and who's going to be holding the position of president and so on. And in the meantime, they've still continuing to ask that we don't make contact with Sandy as he spends one-on-one time with his family, with his sons and grandchildren and other members of the family, and they come to terms with the loss that occurred. Very briefly, I'd also like to say that for the last 3 years, we had a visitor from South Australia, Simon Thiel, who'd come to visit and to be here for TM Day. Sadly, after last year, the beginning of this year, he died very suddenly of a heart attack, but he was a particularly interesting and man and he gave a lot, and he also left a small amount and asked for tributes to be donated to Spinal Life Australia so that they could be used in some way to help with our ongoing activities, benefits and everything else. So that's it about the TMA. There's somewhere around 10,000 people worldwide in the TMA now, which is a pretty phenomenal amount of people. And we have people in there who volunteer to do translations. So we've got, I think, 62, last time I checked, countries involved, speaking over nearly 40-odd languages. And of those 40-odd languages, apparently there were members who were happy to translate in nearly every language that was used, even different dialects and things. So it just gives you some idea of how that association has worked. I'd also like to thank everyone here at Spinal Life Australia, to Ross, who has been brought in the last 12 months to restructure and really take a look at what happens with our member networks. Obviously, he's taking time to come on board and understand what our needs are and what's going to work. And to Jeanette, who's doing the coordination of member networks, so for all the different networks, the Spinal Injury Network, the Post-Polio Network and the TM Network. And there's ongoing meetings, activities and consideration of what kind of functions to best serve these groups of people, and where there's an overlap where we can perhaps get together with another group. So thank you, both of you, and to everyone else that works in member networks. It's a big job, and we appreciate the fact that we're looking at continually trying to improve and have better outcomes. I personally have had a pretty tough year so far, and I just wanted to briefly say thank you for a lot of people here, but from people all over the world. I've had messages of support, cards, lovely cards, and lots of encouragement from people, and I really do appreciate that. Obviously, I've got this role as a voluntary role, and I do my very best with it, but there are times when I can't do things, and some of those people have put their hands up and said, well, what can we do to practically help to make sure an event goes on or whatever. So my thanks to all of you who've done that. I do appreciate it very, very much. And finally, sorry, lost my place. All right, member networks for the next 12 months. As Ross alluded to when he opened it this morning, we've looked at having a bit of a change. Up until now, we've had our TM Day in May, and that's been our main event. And outside of that event, primarily the facilitator, which is me in this case, has helped to organise social events in the wider Brisbane region, from the Gold Coast to the Sunshine Coast and to Brisbane itself. So what we're looking at this stage is holding more events during the year, not just the one TM Day, but looking at different types of things and the most appropriate types of areas that we can help the members with. So we'll be looking to everybody to try and give as much honest feedback that they can, so that we can make sure that we have events that are going to be really practically helpful. And finally, thank you very much, Sam, for your contribution. The NDIS is still of all the phone calls that I have received or make, that's still the #1 topic, and the anxiety perhaps of people, and it's natural, something new and something very different. And for those people that depend on a lot of support, it's perfectly natural that they are going to feel anxious. So getting the ongoing support and knowing that we have help and resources here at Spinal Life is very reassuring, and I think will reduce some of that stress and anxiety that comes with any new system. So thank you to the organisation, to individuals who've helped me, and I know they can't hear me, but to the TMA. There's up to 40-odd doctors who are specialists at the top end of their field who consult to the TMA. Now, we're specialists from Adam Kaplan from psychiatry, 9 neurologists, about 7 rehab experts, and immunologists and endocrinologists and everything else. As we all know, neuroimmunological disorders, or it's now called rare neuroimmune diseases or disorders, are very complicated, and no two patients are the same. And very last thing is in October this year. It's the Rare Neuroimmunological Disorders Symposium that's going to be held in Ohio for the first time. Previously, it's been in recent times in Dallas, and before that, it's been in Marion and in Baltimore. And it's always based out of one of the major universities where there's doctors working in that system. It's a fantastic program, and I will move heaven and earth to try and get there if I can. They're running a 2-day program prior to the event for support group leaders and facilitators, people like me, to try and educate us in the best way of engaging people and giving the best, teaching us best practice, I suppose you could say. So I very much look forward to that. I'm not sure whether we will see Sandy there or not. I suspect, I mean, obviously that's entirely up to him, but he and Pauline will be missed. He's the lifeblood, and apart from Ben Greenberg and Carlos Paulo, the most sought after people at these conferences, having been twice before, are Sandy and Pauline. And Pauline was never alone. She always had Kazoo, her disability dog, with her. So it is going to be a herald a change, and perhaps it'll herald a change in the TMA, I don't know. But if you have any possible way of getting to this conference in October, I would strongly recommend it. And I'd be happy to have a travel companion if you are heading there. So finally, thank you all for everything you've given to me and to shared amongst us during the last 12 months, a bit more, but with that, I appreciate everybody's different efforts to keep our network going. So thank you.
That brings us to the end of the formal section for today. Unless anyone's got any questions. Any questions? Okay. So that's the end of the formal section today. Please join us for lunch. Thank you very much for coming. It's great to put on events like this and see that they're popular. So thanks to Jeanette and to Louise for organising, and Megan for organising the room, the slide connection, the internet connection, and the food.
And Joe, our IT expert. Can't forget Joe. Couldn't do it. And Jim, actually, if you're still there, Jim, our fantastic Jim, who's always there to help us.
Jim and Joe, I think what IT never get is a round of applause for the connection actually working. So if everyone can join me, so really, thanks a lot, Jim and Joe, for making the IT A, connect, and B, function all the way through. I'm standing at the back just trying to prepare some lines to jump in the middle and didn't have to. So thanks a lot, guys. Jim, it was much appreciated coordinating the questions as well, and for making sure that everything ran smoothly right there. So thanks a lot for that. And unfortunately, you can't join us for lunch here, Jim, but I hope someone over there can rustle up some food for you if it's that time of night.
It's almost bedtime, isn't it, Jim? Jim is also 2 hours ahead of Ben. So when Ben was at 9:45, that was 11:15 Jim's time. Is that right, Jim, or am I going backwards?
It's 7:20 my time.
Okay, all right. So, yeah. So.
All right, thank you very much again, Jim, for your efforts today. It's much appreciated. Yeah, the support from the TMA is always greatly appreciated. So thanks a lot. So everyone, if you want to stay around for lunch, that'd be great. And Sam will still be here to ask questions on, and as will I and Jeanette. Thanks a lot for coming today.